Good afternoon, and welcome to today's webinar, Vermont's ACO Shared Savings Programs in a National Context. I'm Georgia Maharis, Project Director for the Vermont Healthcare Innovation Project, as well as Deputy Director of Healthcare Reform for Payment and Delivery System Reform at the Agency of Administration, and I will be moderating this afternoon's webinar. This is the fourth event of the Vermont Healthcare Innovation Project webinar series, which presents a webinar on a new topic monthly on the second Wednesday of the month. Before we get started, I'd like to go over a few items so you know how to participate in today's event. On slide 2, you'll see the attendee interface screenshot. On the left side of this slide, we've included a screenshot of the webinar's attendee interface, the control panel. You should see something that looks like this on your own computer desktop in the upper right corner. You're listening in using your computer speaker system by default. If you prefer to join over the phone, just select telephone in the audio pane and the dial-in information will be displayed. Moving on to slide 3 for some housekeeping. We have set aside time for discussion and questions at the end of this webinar. You will have the opportunity to submit text questions to today's presenters by typing your questions into the questions pane of the control panel. You may send in your questions at any time during the presentation. During the Q&A session, we'll have a moderated discussion to answer your questions. Today's event is being recorded. The slides and recording will be posted to the Vermont Healthcare Innovation Project website, healthcareinnovation.vermont.gov, within the next few days. You'll be notified when these materials are available. At the end of today's event, you will be redirected to an evaluation survey. Please complete this survey. We value your feedback. Finally, I want to thank Chrissy Geiler and Sarah Kinsler for planning this webinar and taking charge of logistics for today. Our presenters today are Rob Houston and Amy Coonrat. Rob Houston is a Senior Program Officer at the Center for Healthcare Strategies. He works on projects involving payment and delivery system reform, providing technical assistance to state Medicaid agencies, provider organizations, and health plans to facilitate the development of Medicaid ACOs and other value-based payment strategies. Rob helps to lead the Medicaid Accountable Care Organization Learning Collaborative, supported by the Commonwealth Fund, which convenes and provides technical assistance to states working to develop and implement Medicaid ACO programs. He has authored numerous publications related to ACO development and alignment. Prior to joining CHCS, Rob consulted with Robert Wood Johnson Partners, a Medicare Shared Savings Program ACO, and the Rutgers Center for State Health Policy on issues pertaining to ACO development. Previously, he was the manager of special projects for Therapy Dogs International, a nonprofit organization dedicated to sharing therapy dogs with those in need of emotional support. Rob holds a Master of Public Policy with a concentration in health policy from the Edward J. Blaustein School of Planning and Public Policy and a Master of Business Administration and Marketing from Rutgers Business School. He graduated with a Bachelor of Arts in Political Science from Rutgers University, New Brunswick. Amy Coonrat is a Senior Health Policy Analyst at the Department of Vermont Health Access. As a Senior Health Policy Analyst, Amy is responsible for offering technical support regarding the programmatic design, implementation, and evaluation of the Vermont Medicaid Shared Savings Program. She works closely with our VHCIP stakeholders, ACO leadership, and various state and federal government representatives to support the Shared Savings Program activities. Before coming to Vermont, Amy worked with the New York City Department of Health and Mental Hygiene, implementing and evaluating an EHR incentive program for behavioral health providers. She completed her MPH with a focus in health policy and management and a certificate in policy analysis at Columbia University's Mailman School of Public Health. Prior to her graduate education, she received a BA in government from Smith College. We welcome Rob and Amy and thank you for joining us today. We'll start today's discussion with a conversation of ACO design considerations, focusing on state Medicaid ACO programs, followed by an overview of Vermont's Medicaid Shared Savings Program. We'll end the hour with some time for questions and answers. Thank you, Rob. Thank you, Rob. It's now your turn to go into your slides. I believe Rob's like to.
Thanks, Georgia. Thank you for inviting me to present today, and hello to everyone. I'm here to talk a little bit about the design considerations when you're designing a Medicaid ACO program. As Georgia mentioned, we at CHCS have worked closely with states, and I look forward to sharing some of the things that we've learned with our involvement with Medicaid ACO programs at the state and at the provider level. Next slide, please. For those not familiar with the Center for Healthcare Strategies, we are a nonprofit health policy resource center. That's what we call ourselves. You can think of us as a little bit of like a half think tank, half nonprofit consulting agency. We typically work in 3 specific areas, either enhancing access to coverage and services, advancing quality delivery system and payment reform, and integrating care for individuals with complex needs. My work tends to fall on the delivery system and payment reform side, and that'll become apparent with my presentation today. Next slide. Some of the initiatives that we are currently working on at CHCS that are relevant to this the context is the Medicaid ACO Learning Collaborative that Georgia had mentioned before. Vermont was a participant in phases 1 and 2 of this program. Also, we are the technical assistance leads for under federal contract with CMMI on the State Innovation Models, or SIM initiative, helping to design and test state-based models for multi-payer payment and delivery system reform. We are also working at CHCS with, as part of the New York DSRIP PPS Learning Collaborative, which is at the provider level to inform the providers of details of the DSRIP program and to facilitate the exchange of ideas across those entities. Next slide. So through today's presentation, I will give a quick overview of accountable care organizations as a concept and how they're being implemented throughout the country, with a focus on Medicaid ACOs. And then we'll go into the key ACO design decisions that come up when designing a Medicaid ACO program. And it's important to know that even though Vermont has its Medicaid Shared Savings Program in place currently, it is very much an iterative process. So you'll, as a state, you'll revisit these design decisions as you look to further develop the program and improve it based on prior experience. We'll also take a look at ACO performance results to date, both through Medicaid programs and the federal Medicare programs as well. Next slide. So a common question is, what are accountable care organizations? And many people have many different definitions for what accountable care organizations are. There's not really a correct definition for what they are. But they are generally designed to hold providers more accountable for improving health outcomes and controlling costs. When you take a look at what a ACO looks like, they tend to include certain specific features, and those are listed on the slide there. Not all of them are present in every ACO model, and it's not like a checklist that you have those, but we've seen ACOs tend to have value-based payment incentives, provider-level financial accountability, robust quality measurement, data sharing and analysis, on-the-ground care management, and provider community collaboration. There's also a movement through SIM and other multi-payer efforts to align ACO efforts across Medicare, Medicaid, and commercial payers. So there are some very different models out there, but they all tend to follow that theme. The Medicare ACOs are the ones that are the most senior of the ACOs in terms of a established program. Pioneer ACOs and Medicare Shared Savings ACOs were the first forays, and there are, building on the Pioneer ACO model, the next generation ACOs were recently announced earlier this year and are underway at this point. The Medicaid ACOs, there are 9 states with active Medicaid ACO programs and at least 8 others pursuing programs. Vermont falls in the active category. Commercial ACOs I like to refer to as the wild, wild west, because they're really, outside of antitrust rules and certain regulations, very minor regulations, they're basically arrangements between health plans and integrated hospital systems that draw up their own shared savings arrangement or pay-for-performance arrangement. They're not very regulated. It's not like a specific program like a Medicaid ACO is or a Medicare ACO. Many of these ACOs that are in place have shown cost reductions and quality improvements, and we'll get into that a little bit later. Next slide, please. So taking a look at Medicaid ACO activity to date, the states in orange are states with active Medicaid ACO programs, and the states in blue are states pursuing Medicaid ACO programs and have not launched yet. Vermont, you'll notice, is in orange. You've been active for, you're one of the more senior programs out there. You'll see that the geographic dispersion of this in terms of conservative or progressive states or states that, or just north, south, east, west, it's pretty broad. There are some goals here that are universal across politics, so we'll go into that a little bit more later. Next slide. So when designing a Medicaid ACO program, or in Vermont's case, potentially redesigning one or improving it, there are three major steps: evaluating the current environment of what is going on in the state, defining the program goals and framework, and then developing a structural model and really digging into the details. All states do perform these three steps. They don't necessarily come in this order, though often they do. And it's definitely different in each step, in each state as they approach these goals, but it does present a helpful guideline for that process. Next slide. So when evaluating the current environment, there's four main factors that determine what kind of ACO program can be developed. Provider readiness is a big part of it. You don't want to design a program that providers are not capable of handling. You don't want to take full financial risk if providers have no experience with that, and you don't want to put care management requirements on them if they're not equipped for working across different organizations. It's very important to know the providers and to respond to their needs. At the same time, it doesn't mean do what they're already capable of doing. There can be stretch goals, and a voluntary program could be something that encourages, or a tiered program could be something that encourages that. Market dynamics are another big thing. Is there managed care organizations in the states? How would they interact with a potential ACO program? Are there any dominant payers or providers that have an oversized share of the marketplace? That's something that will go into the design of the program. Also, can ACOs be built on existing efforts, such as a patient-centered medical home or health home model? And finally, obviously, political factors go into the decision. And we've seen programs originate from legislative law, from the governor's office, from grassroots efforts that really built up over time, and the state said that it's something that we should do statewide. There's many different ways that a Medicaid ACO program can start. After you take a look at the environment, you can define a program goals and framework. You don't want to start from the bottom. When you're building a house, you lay the foundation, you have a structural framework. It's a very stepwise process. You don't construct the bathroom fully on the second floor and then start building other parts under it. There's a very specific way to do it. And this is a good model for building an ACO program as well. You should think about what the program goals are, and they should be clear, measurable, and achievable. And it should address identified problems in the state. It's not going to be a panacea catch-all thing that's going to solve any issues in healthcare in a state or provider organization. You should define the scope of the model. Will it be a pilot or a statewide effort? Will participation be mandatory, or will it be more flexible? And will the rules of the program allow for innovation, or will it be a very specifically designed program? There's also, are there any must-have structural elements? Is there something that the state really wants to focus on, say health disparities, that will be a big part of the program as you get into the nitty-gritty design process? So we've identified at CHCS 8 key design questions when developing a structural model and really digging into the details. And those 8 questions are outlined here. The next slide will go into a little bit more detail on those. Next slide, please. So first question is, who will lead the ACOs? Will it be providers or payers? We've seen both types of models. Providers, in the payer-led models, providers are more actively involved than a traditional managed care environment. Also, will it be another entity or partnership? There are some models out there that are not payer or provider-led, and we'll get into a couple of examples of that in a few slides. Who will the ACOs serve is another key question. Will it serve the full population, the full Medicaid population, full Medicare population, or will it just target a subpopulation, say folks with specific complex care needs? Also, a question that states ask themselves is, should we include Medicare, Medicaid enrollees? Many states already had, when Medicaid ACOs kind of started out, they already had programs in place, financial and alignment demonstrations or DSNP programs that were already doing the job. So they elected not to include Medicare, Medicaid enrollees in their Medicaid ACO programs. How will patients be attributed to ACOs? Would they be retrospectively based on utilization or prospectively maybe by geographic area? It doesn't have to be retrospectively by utilization. It could be prospectively on past utilization patterns. It could be retrospectively on geographic models, but generally retrospective tends to be by utilization and prospective tends to be by geographic means, at least to this point. The services that ACOs provide is also a very crucial question. All states include physical health services in their Medicaid ACO models, and the Medicare models exclusively include the physical health services. But the Medicaid ACO models have taken a step further in many different states. Many states include behavioral health, some include long-term supports and services, oral health, pharmacy, and also non-emergency medical transport. Questions also come up with how the payment model is going to be structured. We've seen pay-for-performance models start with the hopes of getting to shared savings and risk models, which is the most common model for ACO programs. And some ACO models are either transitioning to or already in global or capitated payments. These are models that tend to be payer-led at this point, but as providers gain experience with managing financial risk and patient health outcomes, they might transition into a global or capitated arrangement on their own. Quality measurement is an important aspect as well. How many metrics will be used and which metrics will be used is always a key question. It's important to balance the number of metrics to make sure that the program is working with the metrics that not overburdening providers or health plans on reporting so many metrics. And how will the metrics be tied to payment? Because you want to make sure that say a shared savings model is not encouraging over or underutilization of services. Next slide. And how will data be collected and analyzed is an important aspect of that. We're not going to go into that so much today because I'm not an expert on that. But many states are developing their own models in-house and running their programs themselves, but many others outsource their models and hire contractors to do the work. And in those cases, how would those contractors be utilized? Are they going to be running the program and completely outsourcing, or are they going to run specific elements of the model and the state runs the rest? And in a managed care environment, many states are thinking about how their existing managed care plans will be involved. Will MCOs be part of an ACO, the ACO itself, or not involved at all and completely separate? And what responsibilities will ACOs have relative to MCOs, and it says ACOs twice on the slide, so I apologize for that. Next slide, please. So there are states that are in a similar boat as Vermont, who I know that you're coming up on the third year of your demonstration and might be wondering about what's next. Colorado and Minnesota, two of the older models that are out there, are currently seeking to update their programs to version 2.0 and improve upon their existing programs in 2017. The highlights of what I presented are available for download at the CHCS website with our issue brief, Program Design Considerations for Medicaid Accountable Care Organizations. It outlines these design decisions in more detail and could be a useful resource for states and also other stakeholders that are navigating the Medicaid ACO process. On the next slide, we have, we'll start to talk about individual state models and how they will go into, I'm sure there may be some questions on these later in the Q&A portion, but I did want to highlight a number of different models that have some that are similar to what Vermont is doing and some that are different. Colorado has its Accountable Care Collaborative, which established 7 regional care coordination organizations which are charged with improving care coordination amongst providers. These RICOs are not provider entities. They're not managed care organizations. They are a kind of care coordination entity that receive a care coordination payment between $8 and $10, and if their region outperforms certain benchmarks on quality, they get a pay-for-performance bonus. They also have they outsource their data management. They have a state data and analytics contractor that provides much data to these RICOs who then provide it down to the providers that are serving that area. And the program has saved $77 million in net savings over 4 years, and that takes into account the program costs. Next slide. Minnesota's Integrated Health Partnerships program is pretty similar to the Vermont model. It's built on existing patient-centered medical home model in the state, and it also is modeled after the Medicare Shared Savings Program approach. Minnesota assigns to their IHPs, they call their ACOs IHPs, into one of 2 tracks based on their characteristics. If it's a virtual model, they participate on upside-only basis and receive 50% of shared savings. There is a FQHC-only IHP model that is similar to one that you have in your state, and also has a acronym. Theirs is called FUN, Federally Qualified Health Center Urban Health Network. And they a fully integrated provider, these integrated health systems do bear upside and downside risk, and shared losses are gradually incorporated over the 3-year demonstration process. Providers can choose to participate. It's not a mandatory program, but they have Minnesota has a significant population managed care through legislation. The MCOs, if they are providing care to Medicaid beneficiaries and they are attributed to a ACO based on utilization, they have to share savings with the ACO based on the amount of savings that occur. There's some flexibility in the contracting of these arrangements, but the state is overall has if there's any disputes or they can't reach an agreement with the ACOs and the MCOs, the state can arbitrate. This program has been very successful. It saved $76.1 million in 2 years, and every single IHP has improved quality over this time and performed well on their quality metrics. New Jersey's ACO demonstration project just launched last year, so there's no results yet, but it is based on a regional community partnership model. It is a geographically based model based on zip codes in the state of New Jersey, and they are nonprofit provider-led organizations that cover a self-defined geographic area. The ACOs select the zip codes that they're responsible for. The standards, New Jersey is pretty prescriptive on what these organizations look like. They have to have the written support of all hospitals, 75% of primary care providers, and 4 behavioral health providers in those zip codes. New Jersey is a 100% managed care state, but MCO participation is not required, so it's up to the MCOs and ACOs to negotiate those arrangements. A upside-only gain sharing arrangement is recommended because this was based on a superutilizer model that was prominent in Camden, New Jersey. Some of you may have heard of Jeff Brenner and his work down there. It's gotten quite a bit of press coverage over the years. And in order to target these high-need, high-cost patients, a minimum savings rate that cuts out the outliers in the model is counter to what New Jersey program goals were. ACO performance is measured on physical and behavioral health performance metrics. Next slide. And Oregon's coordinated care organizations are an MCO-driven model. They, like Colorado, they have regions. There's 16 defined geographic regions in the state, and the MCOs apply for CCO contracts through a selective procurement process. The interesting thing about the regional CCOs is they essentially create a monopoly in all regions but the Portland metro area. So you are automatically assigned based on where you live to a CCO. Because it's an MCO-driven model, it's a little different than what Vermont has, but the CCOs are paid through a global capitated payment, and it's capped at a 2% annual growth rate. So if you're a CCO and your costs increase over 3%, you still only get a 2% growth rate for that, for your capitated arrangements and your per member per month payment through the next cycle. The CCOs cover a broad scope of services. It's physical health, behavioral health, and dental services for all Medicaid beneficiaries in the state. It's an auto enrollment. I think they have over 90% of Medicaid beneficiaries in the state enrolled in a CCO, and they include Medicare, Medicaid enrollees in their model. So let's talk about the results to date. Pioneer ACOs, there's been much press on how many have dropped out of the program. They originally had 32. There's now 9 in Pioneer ACOs in existence. Now, some of these have migrated to the Medicare Shared Savings Program or the next-gen ACO models. So that is some of the accounts for some of it. They saved $196.32 million as reported by CMS in its first 2 years, and resulted in the establishment of the next generation ACO model, which is based largely on the Pioneer model. CMS seems to have some faith in that model. Medicare Shared Savings Program is the most widespread Medicare model. There's 338 ACOs participating across 47 states, and that's 4.9 million attributed beneficiaries. And in its first 2 years, as reported by CMS, there was a savings of $372 million over the first 2 years. As far as Medicaid ACOs are concerned, Colorado reported $77 million in its first 4 years. It says 3 years on the slide, but we need to update that. Minnesota saved $76.3, as I discussed before. Your state of Vermont saved $14.6 million in its first year, which is pretty good. And Oregon showed a decrease in inpatient admissions and ED usage, and their CCOs were able to stay within that 2% growth rate that was mandated. Commercial ACOs, the models vary widely, but many have shown promise in savings. Generally, the commercial ACOs don't really report their savings publicly, but they are, sometimes they'll brag a little bit, so you can find some savings on that. All models across the board have shown evidence of quality improvement through an ACO arrangement and greater care coordination efforts. Next slide. So what is the future as Vermont is looking at potentially designing a version 2.0 for the model and looking at trends in other states? What is happening? There's a sea change toward value-based payment. ACOs are a big part of that payment close to 8% of Americans are currently enrolled in an ACO program, so that's pretty significant. Even more are affected by value-based payment arrangements, and that's across Medicare, Medicaid, and commercial sectors. Emergent topics of ACO discussion include population-based models that are serving people in geographic areas. These are similar to the Oregon, New Jersey, and Colorado models I mentioned. Specialized models for specific subpopulations, and high-need, high-cost populations and pediatrics are two areas. These specialized ACOs are popping up more and more. There's also a trend. Many health home programs are looking into instituting shared savings or value-based payment arrangements that will increase the incentive to provide value-based care. There is an increased provider risk. Providers are taking on more and more risk, and the next-gen ACO model is an example of this. And some programs are stating that they would like to go into provider capitated models, similar to how the Oregon Global Payments work. Multi-payer ACOs is also a big trend, and I know that the ACOs that you have in Vermont are designed with that multi-payer aspect in mind and serve multiple payers. Medicare, Medicaid, and commercial are where these function most. Maryland is working on a Medicare, Medicaid enrollee exclusive ACO, and state employees. The states of Washington has a state employees ACO and is working on a Medicaid one, and Oregon is integrating its state employees into its program as well. And I encourage you to visit chcs.org to download quite a bit of resources about Medicaid ACOs if you would like to learn more, and some others about ACOs more broadly. We will be launching through our Medicaid ACO Learning Collaborative a resource center either late this month or early next month, so stay tuned for that as well.
Thank you, Rob. We'll now turn to Amy Coonrad from DVHA to provide an overview of the Vermont Medicaid Shared Savings Program, one of the centerpieces of Vermont's payment reform activities under our SIM grant. Amy?
Thank you, Georgia, and thank you for that overview, Rob. Good afternoon. My name is Amy Coonrad, and I work for the Department of Vermont Health Access on its payment reform team. I'm happy to be on this webinar to give an overview of the Medicaid Shared Savings Program in Vermont and to tie this into some of the design considerations that Rob touched upon in his presentation. To begin, I'd like to offer a little bit of background information. In 2013, Vermont was awarded a $45 million state innovation model testing grant from CMMI. Our SIM work in Vermont is known as the Vermont Healthcare Innovation Project. Vermont's objective for the SIM project was to design, implement, and evaluate a number of value-based payment initiatives over the course of the 3-year testing period. The first such initiatives to be launched were our commercial and Medicaid shared savings programs in 2014. DVHA has assumed the role of administering the Medicaid shared savings program. Our shared savings program standards in Vermont were developed as a result of a huge amount of collaboration among payers, providers, and other public and private stakeholders in a process that was facilitated by the state. Standards were developed around such components as attribution of patients to an ACO, establishment of expenditure targets for an ACO, the distribution of savings for an ACO, the impact of performance measures and quality on savings distribution, and on governance. Vermont has shared savings programs in place for all 3 payers within Vermont, so for Medicare, Medicaid, and commercial payers. When developing standards for both the Medicaid and commercial shared savings programs, we really sought to align with the framework established by CMS for the Medicare shared savings program to the extent possible. So we can view the MSSP, therefore, as our starting point, indicated on this slide by the red box. The Medicaid and commercial shared savings programs were developed in tandem sharing common elements with each other and with the Medicare Shared Savings Program. Each of them were tailored somewhat to meet the specific needs of the unique beneficiary populations being served. ACOs in the state then had the ability, once programs were developed, to enter into program agreements with the commercial payers to participate in the commercial program and to simultaneously enter into a contract with DVHA to participate in the Medicaid Shared Savings Program. I'll now spend a little bit of time walking through some specifics of the Vermont Medicaid Shared Savings Program itself. 2014 was our first performance year, and at the onset, 2 of the 3 ACOs operating in Vermont signed contracts with DVHA to participate. The first is OneCare Vermont, an ACO comprised of the majority of the hospitals in the state. The second, Community Health Accountable Care, or CHAC, is largely an FQHC-based ACO, meaning that its participant network is largely made up of federally qualified health centers. To give a sense of these ACOs, during 2014, there were approximately 38,000 beneficiaries attributed to OneCare and approximately 27,000 beneficiaries attributed to CHAC. Both ACOs were eligible for and received a portion of shared savings in 2014, as Rob touched upon earlier. In 2015, beneficiary attribution increased for both ACOs, with roughly 50,000 beneficiaries attributed to OneCare and 29,000 attributed to CHAC. This increase was largely due to network changes for both ACOs, as well as more of the 2014 Vermont Medicaid expansion population becoming eligible for attribution in this performance year. We are still several months away from our final cost and quality reconciliations for year 2, so we do not yet know if either ACO will be eligible for shared savings in the second performance year. More to come on that later. So regarding beneficiary attribution to an ACO, Vermont Medicaid beneficiaries continue to have complete freedom of choice when seeking care. It's business as usual. Beneficiaries see their PCP as they normally would. If that PCP happens to belong to an ACO, the beneficiary is then considered attributed to that ACO. The ACO assumes responsibility for both the cost of care and the quality of services provided to that beneficiary during a performance year. Providers continue to bill as they had previously, receiving fee-for-service reimbursement. Like the Medicare Shared Savings Program, our Medicaid Shared Savings Program relies on a retrospective attribution methodology, meaning that final program year attribution is not determined until the completion of that performance year. So in order to be eligible for attribution to an ACO under the Vermont Medicaid Shared Savings Program, a beneficiary needs to fall within one of these 4 broad eligibility categories within Medicaid, which are general adult, general child, aged, blind, or disabled adult, or blind or disabled child. There are also a number of excluded populations. Beneficiaries are considered ineligible for attribution if they are duly enrolled in Medicaid and Medicare, have any commercial or third-party coverage, or are enrolled in Medicaid but receive a limited benefits package. For example, if they only receive pharmacy benefits from Medicaid, they're not eligible for attribution to the Medicaid Shared Savings Program. We also exclude from attribution any beneficiaries who have had fewer than 10 months of Medicaid eligibility in the program year. So a very brief word on expenditure targets and the financial performance component of the Medicaid Shared Savings Program. So in a nutshell, an ACO's expenditure for its attributed population is compared to projected expenditures, a trend, for that population. If the actual expenditures during the program year are lower and come under that projected trend, and if the ACO meets pre-specified quality targets, the ACO is eligible to share in the generated savings. Mirroring the Medicare Shared Savings Program, the Medicaid Shared Savings Program offers ACOs a 2-sided track model for bearing risk, one track allowing ACOs to assume downside risk in exchange for a higher savings sharing rate, and one track allowing ACOs to assume no downside risk and a 50-50 split sharing rate between the payer and the ACO. So to date in Vermont, no ACOs have elected to pursue the downside risk track. So both ACOs are on the first track, meaning upside only, and they are not eligible for assuming risk. When calculating expenditure targets for ACOs, the Medicaid Shared Savings Program includes a set of core services that are included in the ACO's total cost of care for calculating their expenditure trend and actual expenditures. These core services are similar to Medicare Part A and B services, the more medical services, used to define the total cost of care for the Medicare Shared Savings Program. So we're very closely mirroring them in that. There are also a number of non-core service expenditures that are not included in the ACO's total cost of care and are therefore not included in the ACO's expenditure for the program year. And these include services such as personal care services, pharmacy services, dental services, non-emergency transportation services that are offered through Medicaid but are not included in the trend. There are also a number of services that are administered by other departments within the state. I'm not going to list them all, but those services are also excluded from this trend. Additionally, we have developed a fairly robust set of quality metrics for use in the Medicaid Shared Savings Program. Our metrics fall into a number of categories as seen here in this very colorful slide. We have a number of quality measures being used for payment, so these include both physical and behavioral health measures. How the ACO performs on these measures influences the portion of shared savings for which the ACO is eligible at the end of the performance year. We also have a set of reporting-only metrics. The ACO's performance on these metrics doesn't influence shared savings eligibility, but the ACOs are required to report on these measures. Beyond these two categories, we have a number of metrics being used more generally for program monitoring and evaluation, allowing us at the program to track trends in utilization and quality over the life of the 3-year program. And finally, there are a handful of measures labeled pending that are of interest to stakeholders that are not currently being used in payment reporting or monitor and evaluation measures at this time. And finally, given that the Medicaid Shared Savings Program is in its 3rd and final year, it's really tantamount to continuously evaluate the ever-changing health reform landscape in Vermont with an eye toward the future. I'd like to note a few key points of consideration when thinking about new payment models and delivery system change. Firstly, we need to ensure that incentives, particularly quality, measurement, and performance incentives, are aligned among providers when considering new payment models, especially when considering expanded total cost of care services or shifting risk to an ACO. Additionally, when implementing new payment models, a key consideration to keep in mind is how providers will be paid, whether traditional fee-for-service through Medicaid or if they will be paid directly by an ACO or a blend of both. And finally, though we only have data for year 1 of the Medicaid Shared Savings Program at this time, we continue to monitor in years 2 and 3 the program to inform development of future offerings in the state of Vermont. And finally, this was a bit of a teaser, and I would like to invite everyone to come back next May and really explore the Vermont Year 1 Medicaid and Commercial Shared Savings Program results. We'll be peeling back the layers and doing a deeper dive into our Year 1 results, and I think it should be really exciting. So please come back. Thank you.
Thank you, Amy. We will now take questions from participants. As a reminder, you can submit questions by typing into the questions pane of your webinar control panel. I will facilitate our question and answer session. Our first question is for Rob. And Rob, you mentioned that provider readiness is a key consideration in ACO design. Mm-hmm. What does provider readiness look like? And then Amy, if you could follow up with what has Vermont done to support readiness?
Okay, so readiness really, and I can probably answer every question with it depends on the model, but it really depends on the model. A ACO program like Vermont's, it's something where are the providers ready to accept upside-only risk and transition to greater risk over time and downside risk. You have to be used to working together as an organization. But if you have a organization that's not, you have provider organizations that are not used to working together and there's a larger scope of services, say there's behavioral health is included, but providers in the state are not used to working with, the physical health providers are not used to working with behavioral health providers, that could be a concern. If providers haven't had any kind of value-based payment experience and you're expecting them to have to do capitation, that could be a problem. But if you're doing something that, and it also depends on the goals of the program, because if you're if you want a large number of providers to enroll in an ACO or ACO-like program, or you want to do something statewide, you have to set the bar a little lower than something that is a demonstration for those that have been doing this for a while, and you want to measure results and encourage future development of it.
Thank you, Rob.
Yeah. So first, if I would say that the atmosphere in Vermont is extremely collaborative, so I feel that everyone sort of has their fingers on the pulse of gauging provider readiness through a lot of communication and a lot of stakeholder work group meetings that we have had here. So we're all in pretty good communication with each other, I would say that first and foremost. Also, through the SIM grant, we have had a tremendous amount of investments in practice transformation activities. Some come to mind, the learning collaboratives that are happening around the state that have been going on for about a year and a half, the core competency trainings that have just started up that are training frontline providers to get on the same page with each other. Also investments in data infrastructure to support communication and coordination among and between providers. I think these are all really good examples of gauging provider readiness and sort of assessing where we are right now and how we can get to where we're going in the future.
Thank you. Rob, another one for you. Looking at the national landscape, what makes Vermont's approach unique?
So Vermont's approach is unique. Each ACO model is certainly unique. There are some models that look like Vermont's. I mentioned Minnesota and New Jersey and also Maine have been largely based on the Medicare Shared Savings Program model. I think that Vermont's kind of claim to fame is you have a large proportion of your Medicaid beneficiaries enrolled. You're also really thinking about aligning it across payers. The fact that you have two large ACOs that have that are Medicare, Medicaid, and commercial ACOs really shows to it's more conducive to a population health aspect of it. I should also mention that Vermont's year one results, especially for a smaller state geographically and population-wise, were very good. It was more savings than either Colorado or Minnesota got in their first year.
Thank you. One more for you, Rob. There's a lot of momentum behind ACOs right now, and obviously the feds are kind of leading that charge. But can you talk about what problems the ACOs are actually trying to fix, and how are they, improving our current system, or what's the hope about how they can improve our current system?
So the goal of ACOs broadly is definitely to improve quality and reduce costs and improve patient experience at the same time. ACO, it's a shift away for fee-for-service, and it's believed that greater provider accountability will lead to both financial and overall quality will lead to improved health outcomes. Some ACOs have been very successful at doing this. Others have been less successful. Some have dropped out of, say, Pioneer programs or MSSP programs. Others have kind of rethought their strategy. I do think that CMS seems very excited, and many states seem very excited about continuing to progress these models. For the providers I talk to, a lot of times it's providers are saying, well, we know this is coming. We want to get out in front of it instead of being forced to change and move away from fee-for-service and revenue-based model.
Thank you, Rob. Picking up on Medicare as a leader in this area just a little bit, and you touched on this in some of your overviews. And while we're focusing a lot on the Medicaid Shared Savings Program, obviously Medicaid is one payer. Medicare tends to be the dominant payer for most providers. So I was wondering if you could talk a little bit about, what Medicare is looking to do moving forward in this area, in particular thinking about their next steps around, Shared Savings Program and Next Gen. and some of their hopes and dreams for the future.
I won't comment on their hopes and dreams necessarily, but they're certainly the next gen ACO model was generally seen as their faith in progressing past the pioneer model and letting those that have done well in that model and others that have done well in risk-based payments be able to take that next step toward a more prospective payment, similar to what the Oregon model is doing. Now, the difference is the Oregon model is a payer-led model. So it's basically provider, CMS seems to want, number one, much more immersion in value-based payment in general, and for providers, and ACOs are one of those models that are prominent. And over time, there's going to be a shift towards more financial and outcomes-based risk arrangements for providers. Now, what this will look like in the future, there are some different scenarios. It could be capitated payments, it could be, or global payments for providers, it could be a different role for health plans, it could be a lot of different things, but they're definitely moving in the direction toward more financial risk and accountability on quality.
Thank you. So Rob, picking up on both some of your updates around Minnesota and Colorado and some of their year 1/year 2 results, could you talk a little bit about how Vermont's year 1 results compared to other states' experience in rolling out shared savings program and other ACO Medicaid models?
Sure, and I did touch on this before. Generally, the year 1 savings are pretty small. Colorado and Minnesota both increased its savings in year 2. Minnesota had significantly more in year 2. I think they had around 10 in year 1, and they had 60 in year 2. Colorado, it's been progressively larger over time. Now, there might be a point in time where there's no more juice left to squeeze. All the savings that could be achieved are achieved, and at that point, you might have to start thinking about another kind of arrangement. But it's something where the savings tend to increase over time, and like I mentioned before, Vermont had performed very well in year 1 and actually had better results than Minnesota or Colorado in year 1 with their programs.
Thank you, Rob. So Rob, I think we're talking a little bit about, kind of comparisons of states, and as you indicated, once you've seen one model, you've kind of seen it, like a Medicaid program. All the Medicaid programs are customized to their state and the state's policy goals. Are there lessons learned that Vermont can take from other states' work in this area? In particular, I'm thinking about some of the expansions into mental health and integration of those types of services that Oregon has focused on, Colorado, Minnesota, Massachusetts, that frankly Vermont has not yet taken as many steps towards?
So I would say that there is a trend for integrating other services. If you're going to have payment reforms and work on quality metrics, because many of the patients that are high-need, high-cost patients and could generate the most savings, could benefit from greater care coordination that ACO mechanism could provide. Aligning the financial aspects or quality metrics of, say, a behavioral health care providers with physical health providers, it goes a long way to, number one, eliminate cost shifting between the different providers, and also just coordinating care better and encouraging the providers to work together on common goals and to exchange data and perhaps work on multidisciplinary teams. So I know that Vermont does a very good job in terms of coordinating and working on complex patients, but that's something that could happen across the payers as well. So states are looking to integrate more services, either financially into the total cost of care calculation or quality metrics tied to payment as well.
Thank you. And one final question, Rob, before we end. We haven't talked really much about services like drugs, and I know in particular Medicare's Shared Savings Programs, NextGen, Pioneer, don't include drugs that are not provided, that are under their Part D program. So I'm wondering if you have any examples of states that are really focusing in on dealing with the drug component and those costs, either Medicaid or commercial or anywhere.
So in commercial models, there tends to be emphasis, and again, there's a lot of variation in these models. There tends to be an emphasis on prescription drugs as well on the commercial models. On the Medicaid side, Minnesota does have prescription drugs in their model, and they've seen savings off of that sector as well as, so it's not, you want to be careful about thinking about like, well, we're saving in the prescription drug costs are going up, so that'll in general the theory is, and there might be different takes on this and how successful this could be, but as you integrate more elements of payment into a ACO model and different quality metrics from different practices and disciplines into a single payment, you would have more of an incentive to coordinate care effectively. So if you're including in that total cost of care calculation, say a pharmacy benefit, that would be something where the providers, the organization, the ACO, would have to account for both of those at the same time, and it eliminates cost-shifting efforts.
Thank you. So I want to thank all of you for attending today's webinar, Vermont's ACO Shared Savings Programs in a National Context. And special thanks to Rob Houston from the Center for Healthcare Strategies and Amy Coonrad from DIVA for presenting on this important topic. Once you leave today's webinar, you will receive a survey on the presentation, and we would appreciate if you would complete that and provide your feedback. You will also receive a follow-up email within 24 to 48 hours with a link to view a recording of today's webinar. On behalf of the Vermont Healthcare Innovation Project, thank you for joining us today, and have a great rest of your day.